Ladies and gentlemen, we have a short time together, and as usual, I do have a lot of things to tell you. There is a lot of new information on tooth whitening. So as David did this very world-stop tour around an aeroplane, mine's kind of going to be on Concorde. So we're going to speed up the pace a little bit to get through some of the information that I'd like to share with you. So whitening is really like a white road or a journey, because it's not just whitening. It's whitening plus and whitening incorporating all aspects of our daily dental practice. I call it the white road. And if you look on this photo over here, there's a fabulous beach, beautiful, peaceful, hardly anyone at the beach. And this was a recent journey that I had to undertake. And I had to walk along here to this building over here. Seems very easy, very straightforward. But what you don't know about over there, where there's a gathering of people, is a nudist beach. And in order to get to that building, you've got to walk straight through the nudist beach. And that is sometimes what happens, is there's unexpected events that happen. You think it's plain sailing, and then you've got to divert your course of action, change, and go with the flow. I leave it to your imagination. So we are going to have whitening as the main part of the treatment, and that is normally undertaken before we start any further treatment. Or we would have whitening before or after restorative dentistry. But in addition, with this maybe new to you, whitening as a therapeutic aesthetics and as a maintenance treatment for our elderly patients. I don't know if any of you know about that, but whitening and the products that we use have been shown to be significantly improving patients' oral health. So if you have an elderly patient who has got early root decay, early tooth decay, poor manual dexterity because of the arthritis, and poor oral hygiene, what you could do is make them a bleaching tray, which we call a therapeutic tray, and administer a program, perhaps with the carer, of one time using carbamide peroxide and one night using amorphous calcium phosphate as an oral health benefit, delivering fluoride, delivering amorphous calcium phosphate, and improving the oral health with carbamide peroxide. So that is a little bit of a different concept. And when you look at what's new in whitening, there's a lot of new innovations in terms of the materials. We now have whitening varnish, which is produced by Philips, and you paint it onto your teeth. And we have the whitening strips, which have been introduced by Henry Schein, and those are 5% hydrogen peroxide strips, which have been shown to work very well. Our basic technique, the home bleaching technique, hello there, is that we make a bleaching tray for the patient and we administer the program according to several protocols. Specifically, we always treat the upper teeth first. I like to use carbamide peroxide, and I'm going to tell you why, but the upper teeth whiten quicker and less sensitivity, and the patient has a color comparison. So it's relatively plain sailing when we do the upper teeth. Then when we introduce the lower, there's a little bit more sensitivity, but because the patient had an easy ride on the upper, they managed with the lower. And we'll talk a little bit about the protocols, the classification that we use, and the fact that 85% of patients who've had whitening come back for further aesthetic dentistry. And when I discovered that, I was quite astounded, and I wasn't ready for the patients asking for further aesthetic dentistry. I thought the whitening treatment was the main treatment, but they come back for more, and we need to be ready for that aesthetic journey to provide the type of treatments that our patients are requesting. And then, towards the end of the presentation today, I'd like to introduce to you the fact that we didn't recommend whitening for patients with tooth wear. And because of the new concepts and treatment philosophies of minimal aesthetics in terms of bonding, we actually say if you're going to do a tooth wear case, you can do the whitening first, and then you can do the bonding. So I'm going to show you a case like that. Of course, those dentists who focus on aesthetics will also be involved in being the oral physician and guiding our patients through their journeys with saliva analysis and assessment, health sustainability, and making sure that they have success and predictability every time. These are some of my textbooks, which Chris very kindly mentioned, and this is the new textbook from quintessence on practice management, checklists, and aesthetic dentistry. But this is the new one. I just got the proof yesterday. So if anybody would like to preview the book and have their name somewhere over here, please contact me afterwards. I'm happy for you to read it. It's got a lot of new information. So a patient like this, we look at this and we're quite astounded. And this patient has come for a second opinion because she was given a treatment plan for 20 veneers, which I suppose is possible, but it's not necessary. And her diagnosis is she has advanced discoloration, she has fluorosis on her teeth. The dentistry and the whitening is very simple because we'll be mainly doing whitening. She has some composite veneers over here. We remove that with a Soflex disc, and we undertake advanced whitening, 8 to 10 weeks of home whitening using 10% carbamide peroxide, and that is the result. Straightforward, and yes, by the way, we did 1 session of microabrasion. Did she need the 20 veneers? No. Will she ever need the 20 veneers? No. Will she need top-up of whitening? Yes. She's going to maintain. This is a case that we've been following for 10 years. Occasionally, every 3 or 4 years, she tops up for 3 or 4 days of whitening, and that's that. These issues over here are not coming back, and we've dealt with that with a microabrasion. We look when we assess a patient with the whites of their eyes versus the color of the teeth. And that's an instant message to see, are we going to be successful with whitening or not? We say nothing, we observe, and we review. And we know that if the teeth are more yellow than the whites of the eyes, it's pretty easy for us to whiten if the patient is going to comply with the journey. But we don't know until the patient undertakes the treatment that they're going to follow the instructions and comply. And that is what our aim is at the end of treatment, to get everything blending in a minimal invasive way. So let's look at our choices. A lot of choice. We did a lot of mechanical interventive dentistry with minimal invasive dentistry. Now we're into minimal aesthetic treatment, and we're into chemical dentistry and therapeutic dentistry. By chemicals, I mean we're using hydrogen peroxide, we're using carbamide peroxide, we're using amorphous calcium phosphate, we're using resin infiltration, which is hydrochloric acid. So we are applying chemicals onto the teeth. But there is also chemicals that the patient has been exposed to that have caused the discoloration. So we're going to look at bleaching and power bleaching and combinations of treatment. And we will know when we want to combine the treatments in different ways. And for patients with non-vital bleaching, that is really a combination treatment. It's not just a non-vital single tooth whitening. We like to incorporate the entire arch if we are doing single tooth whitening, because it's unpredictable and it's unrealistic for a patient, for us to know what shade are we going to match if it's got a dark gray tooth, non-vital tooth, to an upper, let's say upper lateral, which is A2. So we would seal in carbamide peroxide, plus we would make a bleaching tray for the patient. And we make a sectional bleaching tray. And we call that outside-inside bleaching, but we're using both techniques nowadays with non-vital bleaching. And in addition, we make 2 bleaching trays. We make a sectional bleaching tray for the upper, and then we would cut back and have a full arch bleaching tray, so we can control it and manage the whitening. And then there are whitening maintenance treatments. And for certain patients, that's absolutely the right thing to do. So when we're talking about enzymatic bleaching, this is a new technique. And they lower the strength of carbamide peroxide, so they're using 5% lactoperoxidase in combination with 3% carbamide peroxide. That's very low strength. So what happens is that it comes as a toothpaste, and one side a double barrel syringe. One is a bleaching gel and one is a toothpaste, and you mix it together and the patient brushes with it, and we'll have 2 shades lightening with this material. The whitening strips as well, I think, are really for maintenance treatments. They're not one-off treatments, but they are available, they are useful at 5% hydrogen peroxide. And the same with the varnish. Those are for top-up or maintenance treatments. And then the adjunctive treatments, because we mentioned it's a white road and a white journey, we would very often do microabrasion as the secondary part of the treatment, and we are doing resin infiltration as to eradicate the white spots. I don't know if you know, but we have an explosion of white spots on patients' teeth. 20 to 45% increase of patients erupting with white spots on their teeth. That means that all of us need to be ready to treat white spots. And I'm going to show you, is anyone doing resin infiltration at the moment? Anyone here? No, okay. I'm going to show you one person. I'm going to show you some techniques of doing resin infiltration because we have to manage white spots, and it's all due to the anatomy, and we will talk about why we get that. And then sometimes we need to be doing composite bonding as well. So it's whitening, it's microabrasion, resin infiltration, and direct bonding. In order to do successful whitening, we have to classify our bleaching cases and our discoloration because not all cases are the same. So we want to treatment plan and stage carefully. It helps us to set the fees and to assess and cost out the bleaching treatments properly. So you look at a patient like that, the patient says to you, so what's in it for me? Or kind of, what can I expect with whitening? And we look at him and he's a basic A3 shade, but actually, can you see the upper teeth are lighter than the lower teeth, which means that anyway, we know the lower teeth take longer. So it's going to be quite a big ask if you've got to get upper and lower matching. And so it's not so straightforward. And you want to know what shade you're going to go to. So you want to have predictable shade change, stability of color, and especially if you're doing restorative dentistry afterwards, definitely freedom of pain. There should be none of the story, no pain, no gain. It should be no pain. However, we know that 85% of patients have sensitivity during whitening. So that is a side effect, and that's what we have to manage. And that is quite a lot of request for 85% of our patients experiencing sensitivity during the whitening. So we want to have predictability every time. This is a basic bleaching case, slightly more advanced, but that's what the patient wants, and we always need to make sure that if that's what we say the patient can get, that we can deliver that, and be very careful on that. So a basic bleaching case would be no restorative dentistry was required, 4 to 6 weeks to achieve a B1. Just by the way, it's never a 2-week treatment. Although the manufacturers like us to think it's a 2-week one-off, 2-week treatment, it's not a 2-week treatment because it's only getting started at 2 weeks. Because the upper take 2 weeks and then you're going to do the lower for 3 weeks. It's actually a 4 to 6 week program. And the reason for that is that, and this is not talked about, the tooth needs to reach the bleaching potential. If the whitening gel does not get sufficiently inside the nerve and inside the dentine, inside the enamel, you will not reach the bleaching potential and you will not have successful whitening. And that is why it takes 4 to 6 weeks to monitor and to assess the patient, because you need to establish stability with the patient. Intermediate case would be some restorative dentistry was required, a combination of bleaching treatments, maybe internal whitening and home bleaching. That would be an intermediate bleaching case, 6 to 8 weeks to achieve a B1. Because non-vital bleaching takes longer because you have to have 3 sessions to change the dressing. Advanced bleaching would be advanced discoloration, such as tetracycline, minocycline, patients with Roaccutane, fluorosis patients, and patients with complex medical histories, or patients who have existing sensitivity. If they have existing sensitivity, we need to manage that. We would make them a bleaching tray first. We would give them the proprietary whitening gels, the soothing gels. And there's 3 different soothing gels that you can use. You can use the one from Philips, you can use the one from Optident, or you can use the one from SDI. SDI product is called Soothe. It contains potassium nitrate, and it contains fluoride. And you deliver that to the patient. You give them a syringe of the potassium nitrate together with the bleaching tray, and they do no whitening for a week. Calm everything down, and then you can start the whitening. And certain patients may take much longer. So now we have at least 10 years follow-up. The research shows that the protocol which we use, which is Professor Van Hayward's protocol, has shown 18 years of stability. That means they never had to re-whiten, and the teeth stayed the same. It never went, the teeth that were lightened never went back to the original shade. So these are my patients 10 years on. Basic bleaching case from here to here. This lady came to see me because her husband had had whitening, he had an awesome result, and they went to a comedy show. And the comedian picked on the husband the whole night because of his gorgeous teeth. So she walked in, she said, "Now, Linda, seriously, what shade are my husband's teeth? Because I want my teeth whiter than those." But of course, we can't tell. So that's 10 years later. This patient, his discoloration is from smoking, from having a lot of fried food, and his lifestyle, shall we say. That is the result. The silver filling did not change. And again, we need to discuss that with patients. There are controversies related to amalgams and whitening, and we don't have time to talk about that, but maybe if there's questions afterwards. This patient has a basic gray shade, but it's still a basic case. This man was sent in by the wife, and the wife says like this: we are having a personal rebrand of my husband. And in order to do that, the first thing we are doing is having my husband's teeth whitened. And that is the result. And yes, he achieved his rebrand and everything else that went with it. More complicated, non-vital and fracture here, intermediate whitening. This patient had trauma. She was involved in an accident where she had to have 3 years of iron tablets, as a result of which her teeth went gray. And we knew the whitening was going to take longer. And so we were in it for the longer time, which meant that intermediate bleaching was going to be a little bit more expensive. The darker the teeth are, the longer it's going to take to whiten. The higher the concentration, the faster the whitening, but the more the sensitivity. But that is the kind of result that we can expect with intermediate whitening. And those patients are 12 years followed up. They're not just one-off randoms. They're 12 years that we've been monitoring those patients with their shades. And to take a patient from here to here, we now know straightforward using 10% carbamide peroxide. So here she has complex fluorosis stains on her teeth. The brown is due to porosity and food. The first stain to go away is the brown. Brown always goes away first, then yellow, then first brown, orange, yellow, then the tooth lightens, and then we're just left with the white spots. So that kind of scenario is only home whitening, 10% carbamide peroxide, home whitening, and 1 session of microabrasion, which is 5% hydrochloric acid. Now we thought, this is a nice result, but we thought that with this amount of extensive recession, she's going to be sensitive. And that is not, we cannot predict just because they have all that they are going to be sensitive. The only way we can tell if they're going to be sensitive is if they change the bleaching tray more often. If they do a protocol where they use 15 minutes in the morning and 15 minutes in the evening, that will make them more sensitive. But otherwise, the normal factors will not tell us. And then there are the controversies about treating under 18s, which we now know we can treat if there's certain conditions and we are treating diseases. And one of these discoloration is a disease. This patient had fluorosis. If it was your daughter, would you treat her? Yes, absolutely. That is the result. But this is the result after 3 weeks. Doesn't look fabulous, but that's because it's fluorosis and it's going to take a long time. So that's what I'm saying. The brown goes away. Then we've just got orange. So this is the review at 3 weeks. And then that's the review at 8 weeks. So you see, you need to be monitoring the patient all the time to assess that. So I want to show you this little video. Oops, if I can get it back. Because this helps us to understand how the whitening works.
Bleaching removes these colors through the oxidization process. The carbamide peroxide solution penetrates through the enamel into the dentine and into the pulp as it rests in the bleaching tray in the patient's mouth. The enamel should be considered a semi-permeable membrane, which is porous. The permeability, amongst other things, determines how fast the tooth will lighten. As the solution penetrates, it breaks down into oxygen molecules. The oxygen molecules are small and enter the tooth's substructure. The bleaching solution must be in situ long enough and frequently enough to allow the oxygen to oxidize the pigment molecules from a yellow shade to a white shade. Starting at the incisal tip and edge, the yellow pigment cells begin to oxidize to white cells. The tooth begins equilibrating to the new shade. After 2 weeks, the oxygen has dissipated and the actual lightened shade is evident. The patient may experience some sensitivity as the small hydrogen peroxide molecules penetrate the nerve of the tooth. This can occur within 15 minutes of gel application.
So, the fact that the oxygen goes inside the nerve within 5 to 10 minutes means that we really need to assess the vitality of all the teeth. This is not beauty therapy treatment that is a random one-off in the mall. This is careful assessment of any discolored tooth. Any discolored tooth needs a periapical radiograph, and that is the rule. It's really important that you have a periapical radiograph to start and your vitality test, because what you don't want, which can happen, an untreated periapical lesion left untreated can flare up during the whitening because they're putting oxygen into an anaerobic area, and you will need to do that root canal first, not as an excuse because you didn't diagnose properly. And this is not well known at all, and it's our responsibility to exclude all pathology, which means checking for non-vital teeth and undetected periapical lesions. Tetracycline, we know, is complicated. So this is a patient who has tetracycline. She's got white marks. She's got amelogenesis imperfecta. This is complicated whitening. It is manageable, but what is not manageable is these cervical areas. Those orange areas are never going to whiten on the roots, and it is our responsibility to tell the patient straight away before we even start. And those 5 lesions, if she doesn't like it, are going to need 5 restorations, and that's part of the treatment plan. She also didn't like the fact that she had small laterals and the fact there were defects on the enamel. She said no veneers. So here we are after whitening. You see the white areas get whiter after whitening. And so we did the bonding. We had a nice result with the whitening. We did microabrasion to reduce these marks. We did the bondings, the nice glossy look is from the polishing with amorphous calcium phosphate at the end of treatment. Very straightforward, very simple. Now this guy came to see me not for whitening, but because he had a broken restoration. So that is an emergency treatment that needed to be dealt with first. So you go, so Linda, how does he go from here to here? Well, he goes on holiday, and that's why he looks so cool. Goes from nerdy guy to cool guy. Actually, it was a journey for him. It was a long journey because we first had to do this side, this quadrant here of restorative dentistry, and then we went to do whitening, and this is direct bonding. Quite straightforward, but you could see it makes quite a big difference to this patient. Poor oral hygiene, some of these amalgams were fractured. We had to restore those. And here, he has 2 restorations, direct bonded restorations. Let me tell you that his best friend did those treatment 30 years ago. And when you look at it, you say, well, maybe they're not so bad, actually, because if you're going to do the dentistry now, you have to guarantee that your bondings are going to last 30 years, and actually, we don't know. So I've said, well, they're not so bad, really. Actually, we need to talk about the design of the bleaching trays, but most of the time we use a scallop bleaching tray, and if we're sectionalizing, we cut back on either side. So here is the result after whitening. Very nice. We know that these bondings were not going to change, and as part of the treatment plan, we had to do something about that. But what you didn't see, can you see over here? Can you see these white marks? Very documented scientifically. It's called the splodge effect. And we didn't see that coming, did we? It wasn't evident on the preoperative photos. And so what we say is, fabulous, Mr. Jones, the whitening has gone so well, the uptake of the bleach is rapid, which is true. But the reason that you've got those areas is that in that patient, he actually has defective enamel. And that is why it's gone straight into that. When we watch the way the bleach goes, it goes straight into the defective enamel, straight into the white spot, and, by the way, into the cracks of the teeth first. It finds the path of least resistance. So if you have a patient with a crack and you've diagnosed cracked tooth syndrome, make sure that's treated first before you do the whitening. Nice result, A4 to B1. Then we took off the restorative bonds from previously, and gosh, there was quite a lot missing from the tooth. And then we built them up with direct bondings, sectional buildups, enamel and dentine blending in, and that's the final result with the patient. So let's look at things like how we've been doing tooth whitening for 26 years. How has it changed in that time? What's happened is the patient's expectations have massively increased, and that is a big ask on us, and the fact that there's this new philosophy of perfection. And I have issues when dentists call their practices the perfect smile, because life is not perfect, and what happens if their smile is not perfect at the end of it? But we do know we can treat much more difficult discolorations, as I was showing you, with a triple formulation. No age restriction for elderly patients, no age restriction for under 18s if there's a disease process which we can deal with. Whitening maintenance, whitening for life is all part of our oral health improvements. And yes, we do get some patients who are bleachorexics and bleachaholics, but we now know we can spot them because their whites of their eyes, their teeth are much whiter than the whites of the eyes. And all these changes have happened with the whitening gels and with the techniques that we use. But the most important factors, when you look at what are the indications, the contraindications, we mentioned realistic expectations. There must be sufficient enamel, the reduced enamel thickness, the medical history needs to be stable. Pregnant and nursing mothers we exclude, but I mentioned to you patients with untreated, undiagnosed periapical lesions. That is a really important thing to look at, and we should treat those first. But did you know that whitening has massive benefits, which are better gingival health for the patient, improved oral hygiene, and besides the fact that there's improved self-esteem, did you know that it actually reduces caries and it reduces root caries? So part of the plan can be to help patients maintain their oral health, then to say to them, why don't you just brush better, Mrs. Jones? What we do when we see early root caries is we make them a bleaching tray. We call it a therapeutic tray, and we deliver the chemicals according to the patient's needs. And of course, we have to do the correct assessment and correct consent and all those things. That's really, really essential. But I know all of you want to know what's new in the market. So let's talk about that. 3% carbamide peroxide in combination with lactoperoxidase. That's called Whitening, and you can get it from them. This is the new Novon. Did you know that? There is now a 5% carbamide peroxide material available for low sensitivity. Their selling point is that it has tripolyphosphate, which is added ingredient to keep it soothing and protective, which is like hydroxyapatite. So that is new, and that can be used for ultrasensitive patients. Then the normal ones are the 10%, which all of these are fabulous. Sometimes people say, so Linda, seriously, which one do you like the most? All of them are fab. They all have been carefully researched, and they all work effectively. Illumina is at 15%. But most of the products now contain fluoride and potassium nitrate for extra soothing. And then the Night White also contains amorphous calcium phosphate. That's why you've got a double-barrel syringe. So every time it mixes fresh with amorphous calcium phosphate, fluoride, and potassium nitrate to improve the soothing. And then this is our basic limit at 16%, and we can use those. If you use 16%, it's going to go faster, but you have to deal with sensitivity. I rather stick to 10%, then I go up to 16% when I see they're not sensitive to 10%. Why do I like carbamide peroxide so much? It's because it has a slow release. So you have carbapol. Carbapol releases the oxygen all the way through the night for 10 hours. That is why the product stays active for longer. Carbapol elevates the pH as well. When you've got urea inside, because the carbamide peroxide breaks down into urea, urea elevates the pH. It helps with wound healing. It helps with the whole healing process in the mouth. That's why we like it, because it elevates it way over 8, about 8. And then we have the potassium nitrate and the fluoride. And so it's slow release. If you are using a daytime product, all the oxygen is released within 30 minutes. So these are the lowest strength now. That is new. And these are the hydrogen peroxide day products. You can use the day products which are assisted. You can use a patient's bleaching tray and put in 6% hydrogen peroxide as a chairside procedure. You can administer it directly to the patients. You can heat up the bleaching gel in a cup of water. You can take the bleaching gel and you can, once you've placed it on the teeth, take a piece of cling film and wrap it over. All these methods are to help and advance the whitening to speed up the reactions. What the companies have done is they've put in extra catalysts to massively speed up the reaction, because now we used to use 35% hydrogen peroxide, and now we use 6% hydrogen peroxide. So they've added extra enzymes and extra catalysts to start the reaction much quicker so that you can get a better result. And in terms of the hydrogen peroxide products only, this is the 5% one. These are the 6% ones that we are using for our treatments. You want to take a picture? Okay, there you go. So we know this is the key product, and we need to be doing home whitening really, really well. What are the things that can go wrong? We mentioned sensitivity management, gingival irritation, and I showed you the splodge effect, which happens a lot, and sometimes we can't predict it. The uneven bleaching, the unrealistic patients. Did you know this? The third day of whitening is the most sensitive. Did you know that? And do you know why? It's because there's maximum saturation of oxygen in the nerve at that time. So we tell the patients, and they then are fine with it, because once you've told them and it happens, it's not so bad. So then a lot of research studies looked at how are we going to tell whether our patients are going to be sensitive or not. But really, it's up to us to question our patients to get a better history, find out about cold sensations, heat sensations, sensitivity to sweet, and pain on biting, because all of those mean different things, which means we have to radiograph and carefully assess to make sure. So guys, I'm going to just let you take a photo of this. And this is, this to take a photo, that's the easiest thing. We don't have time. But this is your key thing of what you need to do when you're managing sensitivity. All those treatment options, there's a lot we can do. So we're going to get 85% of patients experiencing sensitivity. This is what we're going to do in variations. Okay? This is my other favorite product, which is Hurry Seal, and we directly apply it onto the teeth. This is from Payman, stopsensitivity.com. And then you cut back the trays. A lot of the time, the patient's trays are overextended, so we cut them back. This is the relief gel. So on one side of it is ACP, and the other side is fluoride and potassium nitrate. And it's very effective. So on our timings, I'm just checking we're good. Let's now talk about whitening plus, because whitening plus involves the additional treatments. And I mentioned to you that a huge increase in patients with white spots. Sometimes we're going to monitor them. Sometimes we're going to apply chemicals such as amorphous calcium phosphate. Sometimes we're going to do whitening, or we're going to do prolonged bleaching treatments where we need to extend the bleaching for 8 to 10 weeks. Or if we're doing tetracycline plus white spots, we're going to go 3, 6, 9, or 12 months. Then we're going to do microabrasion using either 6% hydrochloric acid or 10% hydrochloric acid. Or we're going to do the resin infiltration at 15% hydrochloric acid. And this is quite new. Or we're going to do some mega abrasion. But what we are doing with advanced markings and advanced white spots is we sandblast them first, then we resin infiltrate, then we sandblast again, and then we resin infiltrate. So I'm going to show you this on a video. And then we have to do the direct bonding and all the other things that we would do for management of white spots. We're talking about either this or very, very extensive white markings on teeth. But we always whiten first, because when you whiten, a lot of the white spots will actually disappear. And so we only left then with the white spots that we had that haven't disappeared with whitening. And then either we're going to do microabrasion, which is a lower concentration of hydrochloric acid, or we're going to do resin infiltration. Here's another slide. I'm happy for you to take a photo. Because there are 100 reasons why you get white spots on teeth, just by the way. I've just shown you a few. For example, I bet you didn't know this one. This plastic has got bisphenol A inside, and we drink it. If it's in the bisphenol A's in the pacifiers, and the children use the pacifiers, they get white spots on their teeth, especially if you're a rat, because the research has been done on the rats, but shown that. But I'm serious. Every chemical, every antibiotic, we only thought it was tetracycline. Amoxil has a very specific pattern. Amoxil white spot markings go along with little tiny lines along the enamel, the lines of the enamel development. So every antibiotic, every medication that we take affects our teeth even as adults. So all the childhood illnesses, every high fever, congenital birth, and MIH. Who has MIH patients in their practice? One. I'm sorry to tell you, all you guys, we've all got MIH patients in the practice. MIH means molar incisor hyperplasia. In the UK, we're not hot on it. But now I'm telling you this, go and see your patients on Monday, and you'll see if they've got white markings on their first molars, they will have white marks on their central incisors. And that is a window between 2 and 5 months. When it develops, that is when the white spots are coming onto the teeth. And it's very specific. And there's many variations of this. I've written 2 chapters in my new textbook on it. But all of this needs whitening first. So there's a lot of whitening that's going to be done, and then the microabrasion and the resin infiltration. So the microabrasion, we take the paste, tons and tons of research. Take a photo of this. You can look at the 20 years of research that has been done on this technique developed by Ted Kroll. It's hydrochloric acid gently polished onto the surfaces of the teeth. Like this. Take a patient like this, whiten them first. This is 10%. This is the Prima case. Prima is 10% hydrochloric acid. And then we whiten. Very simple result. Now we've got more complex whitening. These are taken away with resin infiltration. So the protocol is simple. Here, whiten first. Can you see the patient has yellow marks on the teeth? The yellow marks are actually old orthodontic bonding. Actually, that was really easy to take away, but we didn't take it away straight away. We waited until we'd had the full diagnosis, the patient had consented to the treatment plan, and then we took away the yellow marks straight away. And then this is the result after whitening. Can you see there's some result, improvement? And this is the result after resin infiltration. And that is quite significant. So let's show you now. This is the protocol. Please take a photo of that, because it's a very specific protocol with a very specific menu that you need to follow. So you clean the tooth first. You would etch for 2 minutes. We don't normally etch for 2 minutes. We normally etch for 15 seconds. But this is quite a big difference. 2 minutes etching, then you place the alcohol, then you do the resin infiltration for 3 minutes. That's quite a long time. Then we lacquer for 40 seconds, then we resin infiltrate again. If you have a complex lesion, you would sandblast first, then you etch, then you go back and sandblast, then you etch, and you can do that 3 times. So this is a lady, we didn't do anything except resin infiltration. And I think that's quite impressive when you see you can do that in 20 minutes. Let's show you the video, and we can turn it up now because this is the 3 components. First one is the etch, which is 15% hydrochloric acid. The next material is the alcohol, which you apply after you've done the etch. You've got to twist it. It's quite unusual. It's not a plunger. You've got to twist it, and you've got to hold it with 2 hands. And that's the alcohol, which is used as a test afterwards. So you twist that as one and drip it onto the teeth to make sure that the white spots are evaporating. And then you use the syringe for the resin. You apply it on for 3 minutes. You twist it on, and then you apply it directly onto the teeth. Let me show you. You'll see a little model of how we're doing that. You need to keep surface contact all the time when you're using a sponge. So what happens is it's absorbed into the teeth, So you need to keep applying the H onto the teeth. All the way through the 2 minutes. We set the timer and then we keep applying it directly onto the teeth. And then we use a brush as well to agitate directly onto the teeth. This is the mini dam from DMG, which is already marked, so you can just put it onto 4 teeth directly. Then you remove it with the water, and then you place the alcohol. And the alcohol will tell you whether or not you've been successful, just from etching that you've removed the white mark. You see how we just gently drip it onto the tooth? And it evaporates inside as an absorbed, because the white mark is a little air bubble inside the enamel. And that's why you need the resin infiltration to infiltrate inside. Then you're going to put the resin on the tooth, and that's a long time to keep applying onto a tooth, 3 minutes. All the time you need the surface tension, all the time replenishing with the resin. So we keep applying this directly onto the resin so that we get in contact and that we can see it evaporating in front of our eyes. The white marks disappear. But before you light cure, you need to floss between the teeth so that it doesn't get caught in between. Very simple flossing, then you would light cure, 40 seconds of light cure, and then you would apply it directly onto, then you would apply it again. So now, let's just stop that. And I just want to show you how to sandblast. When you're doing a more complex lesion, let's just show you here. So you see a patient like this has got quite extreme white marks on the teeth. What we did is we took them away with whitening and with resin infiltration. I think that's awesome. I was like, wow, you can do that with resin infiltration? That's pretty cool. So let me just show you here. So we etched the teeth, and when we finished whitening, we sandblasted. We sandblast, sometimes we have to sandblast 3 times. So you etch and sandblast, etch and sandblast. And there it's about to go, there it's gone. So this is to show you that you can do quite extensive lesions like this. The last thing I want to show you is the fact that we can do whitening with the restorative treating wear cases. We always thought that it was completely pointless, but now treating these patients. So the protocol for these patients would be, first of all, we get them stable. So we build up the composite restorations. We build them up with a vertical dimension. Then once they're stable, we would do the whitening. You can see on this patient the extensive problems, extensive tooth wear. And here are the bondings and the diagnostic wax up with the stents that we do. I mean, this is pretty big ask to undertake that. But first we did the restorative where we built up the bonding. Then we did ortho to bring this forward. You can see quite extensive aesthetic problems. Whitening is not going to solve these issues, but whitening is going to be part of the journey. And that's why I wanted to show you that we can include it as part of the journey. And so here is having the ortho brought forward after we'd established a new vertical dimension. And then we're going to whiten, and then we're going to put palatal veneers. So that's the palatal veneers in place after the whitening, and you know that you need to wait 2 weeks after you finished whitening for the bond strength to be reestablished. Those are the palatal veneers placed on the teeth, and that's the preparation. It's a really tricky thing to do. It's not whitening. This is much more complicated because you need to separate all along. And those are the palatal veneers I showed you, and then we did some buccal veneers for the patient after that, and that's his final results, and that's his journey. So, ladies and gentlemen, I've given you a very quick, brief journey. This is what we use for whitening maintenance. We use all those different products for maintenance, for improving patients' oral health. I like to be proactive to improve our patients' oral health, and we changed the name of the bleaching tray to a therapeutic tray. Very simple, but we administer the same design with these different chemicals For these type of treatments, even peri-implantitis patients, we can use the carbamide peroxide because it's shown to be more bactericidal than the Corsidol. So that's shown to be very, very effective. Last little thing that we do when we take the patient like this is we do enamel surface treatment. Before we do any final bonding, we use the aquacuts. I like to use the silk, which is calcium and phosphate. We whiten, with normal whitening when we clean, we use the silk as a preparation technique, and here we finished whitening, we're going to do the bonding, but you can see the teeth are still coated with plaque. We do this with the abrasion with the aquacut. So when we have our patients who have early root caries, we apply the amorphous calcium phosphate, and we discuss with them how they're going to do their protocol. 1 night whitening, 1 night using amorphous calcium phosphate in that way, either with the Remin Pro. So ladies and gentlemen, I know I've given you a very fast tour, but there are some success strategies, and number 1, it says, always listen to the patient, understand what they want. Classify the bleaching treatments, and so that you can design your whitening cases accordingly. Learn to treatment plan to include all the comprehensive treatment that we need to provide for the patient. Everything should be listed before we start the case. Patients need written instructions. The consent needs to be very detailed these days as to know what the risks and benefits are, what will happen, what will not happen, so the patient is fully informed. We know that aesthetic dentistry is one of the most important behavior-changing experiences that patients can undergo. I think that often we are very honored and privileged to be on the journey with our patients to see the results, and it's quite rewarding for us to do that. So carefully understand what it is the patient wants. Always act in the patient's best interest, providing very conservative options with the patients knowing the risks and benefits. This is my email. My website is lindagreenwall.com. My Facebook is Dr. Linda Greenwall. Please find it because the little videos are all there for you to download and to use to show your patients for patient education. And our next training course, if you'd like to come along, it's an advanced training for 2 days, is the 17th and 18th of November. Ladies and gentlemen, thank you very much.